some time now. And for those who do not know me, I am the head of oral medicine and radiology in Penang International Dental College. A little bit about myself. I am in Malaysia since around 12 years now. Been teaching in PIDC, and I enjoy teaching and the company of students. So that's how we're on this platform today with interpreting panoramic images. So I guess I will start now, so that now I think it's about 2 minutes since all of you have settled in. Right. So the contents of this topic today would be introducing to you certain key terms, moving on to a little bit of introduction about the principle of panoramic radiography. I know it sounds boring, but I'm just going to keep it very short. A little bit about radiation safety, basic anatomy, that's very important. We'll try to figure out what is where on a panoramic radiograph. And interpreting panoramic images, that's the most important part. We'll be looking at lots of cases. We'll be discussing what we're seeing on those cases. And at the end, we'll look at some indication strengths and limitations. After which we'll have a Q&A session. Feel free to ask me your doubts even during the presentation. I will try to keep it as interesting and precise as possible, right? And I would want to warn you in the beginning, this is going to be an interesting and feast for your eyes. So you need to keep yourself glued to the screen. And I would believe that the pleasure of the webinar would be better if you're using a larger screen and not your mobile phone. So you still have time, you can switch. Okay, so moving on to the key terms. Tomography, I would just be using this term briefly, which means body section radiology or radiography. Digital imaging, we know what that is already. If we do not, then instead of using films, we use sensors, and of course, there's an X-ray source. Focal trough, that's an important term. It's a three-dimensional curved zone where the structures lying within this layer are reasonably well defined on the final panoramic image. Ghost images, shadows of objects located between X-ray source and the center of rotation that get exposed twice. So we look at some of these in the presentation. So a little bit about the introduction, first of all. Panoramic radiography is an extraoral imaging modality. That means the imaging source and the imaging receptor, that means where you capture the image, are all outside the mouth. So here you can see that the person is standing in inside the confines of the machine, and there is someone who is trying to adjust the parameters in the machine. So the important things that you need to understand in a panoramic machine are that would be the X-ray source. You have a digital sensor on the opposite side, and both the source and the digital sensor rotate around the patient's head at the same speed in the same direction. The patient is wearing a protective lead apron. It's very important to note here that the lead apron for panoramic radiology, it doesn't cover the thyroid collar. Because the thyroid eventually does get exposed to radiation. Otherwise, if you have a collar which is covering the thyroid area also, you could get marks of the lead apron or images of the lead apron on the final image. So it obscures the area that needs to be seen. That's the bite block on which the patient is supposed to bite and stabilize so that he or she is standing within the focal trough and is positioned correctly for taking the image. And that's the software used to view the image. Since we have all moved to digital radiology, it's important to understand that there is no film, there's no darkroom procedure, and the image directly gets transmitted into the computer, and you view it with the help of a software. Right, so moving on to the principle of panoramic radiography, it is based on the term tomography, which means body section imaging. It is like actually having this loaf of bread, and you're able to individually see one slice of the bread and able to see the structures within that particular slice. So what happens is there is reciprocal movement of X-ray source and the image receptor around the center point. Now this center point, to make you understand, is actually the area which is the focal trough, or a horseshoe shaped three-dimensional area where the patient's jaws, upper and lower, lie within, and all the structures around that get blurred. So only this particular area gets exposed to radiation. When the X-ray source and the receptor move in the same direction at the same speed, and the X-ray shoots the area of interest and it gets captured on the image. So this is how your patient is positioned. I have taken this image from a source, and this is the area of the jaw that gets captured. So eventually the X-ray machine is able to show you one particular slice of your maxillofacial region, so that it gets spread out wide and is seen as a flat panoramic image. So that is the reason why that area of the jaw has to be positioned correctly in the focal trough or the image layer. It's important that you follow the guidelines. There are certain laser pointers which help you focus and help you align the patient in the machine. Almost all machines have those. It even indicates to you the Frankfurt horizontal plane so that you understand how to position the patient's head both in the y-axis and the x-axis. So like I told you, the X-ray machine is moving around the patient's head, and then the center of rotation generally moves along with the machine. That means is not always a fixed center of rotation. It's called as a moving center of rotation. So if you've noticed in this image, you will see that there are multiple black dots indicating that at various points when the machine is rotating around the head, the center of rotation also changes. Essentially, the patient's head is fixed in one particular position. The X-ray source is on one side and the image receptor is exactly on the opposite side. So these are some steps to image acquisition. First, the X-ray source. It produces a cone-shaped X-ray beam, or sometimes a slit-shaped X-ray beam. It captures the area of interest on the receptor, and this receptor then converts it into digital data that can be viewed on the computer. Now, this is a simple panoramic radiograph that is a result of the imaging, and you can see it's actually one of our cases which we had seen a couple of years ago. And in the final panoramic image, you will be able to see that there are some numbers over here, and the image clarity is excellent. And you can see that this is the voltage and the milliamperage. So the current and the voltage in a panoramic machine can be changed based on your size of the patient. So obviously an adult will get higher radiation exposure than a child. So that gives you the freedom to change the radiation exposure. So moving on and keeping with radiation exposure, what is important to understand is that panoramic radiography has a relatively low patient radiation dose. Now, when we mean by relatively low, we're talking in comparison to a dental full mouth series of IOPs versus a chest X-ray or versus a CT scan. So definitely CT scan, CBCT scan have higher radiation dose, and chest X-ray also has slightly higher than a panoramic radiograph. When in comparison to full mouth series of IOPs taken with even digital imaging, the panoramic radiographic image requires less amount of radiation exposure. So if you were to see broad coverage of the entire dentition, then a panoramic radiograph would be the right choice. That is what is the clinical implication of this of this point. So when you expose the patient to one panoramic radiographic exposure, the typical effective dose is about 9 to 26 microsieverts. Now, why is there a range? Because like I told you, you can change the radiation exposure to the patient based on the size of the patient, which essentially the amount of exposure is equal to 5-hour airline flight. So that's the amount of radiation exposure you get when you're at that altitude and getting exposed to a cosmic radiation, which is there all around on planet Earth. So which is also equivalent to 2.5 days of equivalent background radiation on Earth. Now, you will understand these terms, effective dose, equivalent dose, if you have understood radiation physics and biology a bit. But if you haven't, you just remember that a panoramic imaging produces the same amount of radiation dose to the body, which is equal to you taking a 5-hour airline flight or staying 2.5 days on Earth. That is to simplify it. So that's nothing to get scared of. It shouldn't scare you from taking diagnostic imaging, because diagnostic imaging can be lifesavers. Okay, so what is important when you're looking at radiation safety is that there should be good clinical judgment. So you will only use a panoramic radiograph when you know it is indicated for your patient. You need to apply evidence-based imaging guidelines and, of course, best practices in imaging and protection. So which means that you should have done your patient clinical examination before you decide whether a panoramic radiograph is good for your patient or no. Right. Now let's move on to the more interesting part of the webinar that you've all been waiting for, interpreting the panoramic images. Okay, so when you're interpreting, there are some things which are important and you need to keep in mind. That is a quiet viewing room and an appropriate ambient lighting. That means now we are all viewing images on a computer, so it's important that you don't have too much of noise around you, so it lets you focus on the image, as well as you have proper lighting, is your screen is well lit, as well as surrounding lighting is not too bright that you actually miss the focus on what you're supposed to see in the image. So that is what is the meaning of that. Okay, so there are very important tips when you scan through the image. I hope you can all see clearly. At any point in time, if you cannot see, please ask the organizers. You can write in the chat box, or you can just unmute yourself and tell me what is the issue so that I can address it. Right, so I am starting off with how to look at the image. Now, this is a typical panoramic image. You can see all teeth in the dentition, and you have a lot of confusing areas here, and it's sometimes difficult to make out what is what. So an important tip to scan through would be in your eyes to divide the panoramic image into 9 segments. Now, this is a very key step to any interpretation of an image on a screen, right? So it's always important to understand that when you're looking at an image, you need to locate whether this is the right of the patient or the left of the patient. All panoramic images will generally have an L or an R written in the bottom corner to make you understand that you're actually looking into the patient's mouth. So when you're looking at the image, you always interpret your left-hand top corner as first quadrant and the right side as your second quadrant of the patient. So when you are interpreting, you will divide the area into 1, 2, 3, 4, 5, 6, 7, 8, 9. So your eyes need to move from 1 to 9 in the same sequence. So this way you will not miss any area. So it's important to follow the steps from 1 to 2. Move on to the first segment. Then you scan the mid-facial region. Then you go to 3, which is the left side condyle. Then you move to 4, which is the angle of the mandible on the left side. Then you move to 5, which is the actual dentition area. 6 and 7. 6 is the right angle of the mandible. 7, you would be able to see any hyoid bone or any areas which are beyond the mandible. 8 is the lower body and the symphysis area of the mandible. And 9 is again on the outside where you can see the other structures beyond the mandible. So this way you will not be able to miss any important finding on the image. I hope you have got that. Right, so now I'm going to talk about some basic anatomy. Now this is a very interesting part of the whole presentation because I want you to pay close attention. Now when we're doing anatomy, we should remember that there are maxillary landmarks, mandibular landmarks, and other shadows. Now, panoramic radiograph is unique because you're taking out, remember I had shown you the picture of the loaf of bread and you're actually picking out a slice and trying to view that image. So that slice is this particular image. So when you're trying to actually make out structures in that particular slice, a lot of overlap of anatomical structures take place. So it's important that you understand which part of the face you're looking at, so you do not have these, or you can erase these overlaps and look at actually what the area of interest is. So let me start off with, like I told you, from the first segment to the ninth segment, and let's look at the most important landmarks that we're looking at. Okay, I start off with maxillary landmarks. Okay, so when you're talking about maxillary landmarks, the most important one that we all would like to identify with is the floor of the maxillary sinus, right? This is the hard palate. I hope you're all with me in this, right? This is the nasal septum. Yes, nasal concha. Concha is the soft tissue inside the nose. So by now you would be able to make out what is radio-opaque and what is radiolucent. Remember, soft tissues cast a gray shadow, and air, because the sinus is filled with air, is actually casting a black shadow. This is the anterior nasal spine. You have the incisive foramen here and the intermaxillary suture. Can't really make out that area very clearly. You can even see the septae within the sinus here. Yes, and then you can see the zygomatic arch in the process, right? Now, I think I've pretty much told you the most important maxillary landmarks. Just for you to understand, this is the floor of the orbit. So now you know exactly where you are, right? So there are more landmarks, but I do not want to confuse you because I understand that most of you find panoramic very confusing. So it's just at the beginning. So let me just stick to most important landmarks. So I will just point out the zygomatic arch on the other side. And if you pay attention, you can actually see a suture over here. Okay, moving on. Now, this is the coronoid process. This is the sigmoid notch. And this would be the condylar head and condylar neck, right? So condyle, coronoid are part of the mandible. And you were aware of that. Moving on, this is your external oblique ridge, which continues as internal oblique ridge. We have the beautiful mandibular canal here. That's what is very important landmark that we need to trace out. All right, so I'm tracing out both the what do we call the landmark, the upper and the lower border of the mandibular canal. This is your angle of the mandible. This is sometimes called as the gonial angle. Right, and here you can see the mental foramen on this side as well. This is the lower border of the mandible, which you can see, and this is your hyoid bone. Right, so have I missed anything? Yes, of course, this is your styloid process there on both sides. External auditory meatus, this is a shadow because it's supposed to be a hole in the ear. These are your cervical vertebrae. All right, so this pretty much sums up all the landmarks that you can see in the maxillary and mandibular region. Of course, various radiographs will show you some various landmarks in more detail. But if you're able to identify these basic structures, then you are having most of it sorted out for you, right? So it's important to understand this. Now, when we're talking about other shadows, these can be quite confusing. I will show you further images to make you understand, but I am talking about shadows like these. Okay, perhaps I should change the pointer color to make you understand that these are shadows which are seen on the panoramic radiograph. This is actually the air space or the nasopharynx and the oropharynx, which you can see on both sides. And it can be quite confusing because they cast lots of shadows, and that's why the panoramic imaging can be a little confusing, right? So even there are shadows over here, but it doesn't mean that that is a pathology. It is not. It's important to look at the border of the intact bone to understand that those shadows are superimpositions of soft tissues. So another term which I should stress on is superimposition. All right. Okay, so let me move on to the next slide now. Yes, so that's all the landmarks that I have outlined for you. So you may want to try to test yourself in guessing what these landmarks are. This is one thing, dotted line, which I haven't mentioned in the previous slide. This is actually your earlobe casting a shadow. So like I told you, a lot of structures overlap over the maxillofacial region. You're just trying to take out one slice and look at it. And that's why you have a lot of structures in front of the mandible and behind the mandible, which could cast shadows, but your area of focus still remains the maxillomandibular region. Okay. Right, so this is the air shadows. I've taken this picture of the internet, which shows you the nasal cavity, the glossopharynx or the soft palate, the oropharynx, nasopharynx, the external auditory meatus, okay, the epiglottis and posterior part of the pharynx. So all of these shadows actually superimpose over the X-ray and may give you a slight confusing image, but what you need to understand that this will always be there because those you can't take out those structures and take an image, because remember, we're doing a two-dimensional imaging. Right. So an interesting term that is there with ghost images is that they are formed by not only metal objects like I've shown you in this image, but also the bone and the soft tissue itself. This happens because as we discussed, the principle of panoramic imaging, both the X-ray source and the receptor are moving at same direction around the patient, and the X-ray is actually exposing the jaw multiple times. So there are chances that few areas get exposed twice. So when this happens, they end up causing a second image, which is a ghost image. So what happens with the ghost image is, for example, this case was an X-ray was taken with the earrings deliberately to make you understand what ghost images are. So the impression of the left earring is actually the shadow, I should say, the left earring is actually on to the right side of the radiograph, and the right earring is on the left side. So most of the landmarks, whichever get exposed, also end up casting shadows on the opposite side. So the ghost images have the same morphology as the real counterpart. They appear slightly higher up. They are blurred slightly vertically, as well as they appear larger. Okay, so larger, blurred, higher up, and have the same morphology as the real counterpart. And very importantly, they appear on the opposite side, right? So you must understand at this point, by looking at panoramic images, that there is a slight amount of magnification of images which happens. But that magnification can be because that's the way the principle of the imaging is. There is 7 to 8% of magnification, but it really doesn't take away the ability to interpret the image. Okay, so when you're talking about panoramic radiography, positioning is very important. Now, this is a classical image which we have taken from White and Farrow, which shows you that it is important to place the jaw of the patient in the focal trough. So what they did was an experiment, and this is the ideal positioning where the patient bites in the bite block. They tried to put a metal ring here and take an image. When the patient is positioned ideally in the focal trough, the image of the ring has no distortion, very minimal. It looks exactly the same as the original size. But when the position of the jaw was far away, inwards, away from the focal trough, the magnification of the teeth happened and they looked fatter. It was a horizontal magnification. So all the teeth looked fatter. When the focal trough or when the jaw was placed inwards to forward, there was horizontal minimization and the ring appears or the teeth appear narrower. So to avoid these falls, it's important that the patient is positioned correctly in the focal trough. So there is a lot of emphasis on patient positioning in a panoramic radiograph, but the machines that are available nowadays help you easily guide the patient into the position because you have identification marks as to where exactly the patient's head has to be positioned. So either the patient is standing or sitting, you can still do the imaging by using those guidelines. And a little bit of practice goes a long way. Right, so let's go to the cases particularly. Okay, so before we start off with cases, I want you all to understand that panoramic radiographs have specific indications. They are generally used for overall evaluation of dentition and can be used as a screening or a scout image. They are used for examining intraosseous pathology. That means not soft tissue, but something which is there in the mandibular bone, like for example, cysts or tumors or infections. Also for gross evaluation of the TMJ, if there is a major fracture or if there is a bifid TMJ or if there is resorption of the TMJ. But minor conditions of the TMJ cannot be easily evaluated on the panoramic radiograph. So if you're having a problem with the disc, I'm sorry, it cannot show you soft tissue. Right, because it's important to understand that this is actually a plain image, right? Plain radiograph. Next, it is excellent for evaluating position of impacted teeth. It gives you an idea of overall appearance of where the teeth is located, impacted teeth. Evaluation eruption of permanent dentition, a must radiograph before you start orthodontic treatment. So to understand where exactly your teeth are located and at what point of eruption are they in at the moment of starting the treatment. And of course, very vital tool in dentomaxillofacial trauma. So I'm not talking about head injury, I'm just talking about dentomaxillofacial trauma. It can act as a very good screening tool. And of course, if the trauma is involving more intricate areas of the maxilla, sometimes you might have to go in for a CT scan. And also for viewing developmental disturbances of maxillofacial skeleton. Okay, now why are all these indications important is that panoramic radiograph is really convenient. You just need to make the patient stand in the machine still for about 20 seconds and the job is done. Right, so let's start looking at individual cases. Now I have a collection here of about 20 odd cases which are all from our bank in PIDC, and I'm very thankful for that. So I have used all original patient radiographs. So of course, you will not be able to identify them. Right, so this is why we've taken a panoramic radiograph that we're talking when I was telling you that we're looking at overall evaluation of the dentition. So what you can see here is a grossly neglected oral cavity, lots of root stumps and teeth which have lost attachment completely. So this makes you understand that actually all of these teeth will require extraction and followed by denture fabrication. But importantly, it also shows you that there are some periapical lesions, although you are not in a position to say what exactly they are, but definitely this patient requires total extraction. Now, it is a very nice and important tool to view the implant that is placed. Of course, for implants, it's better to move in for CBCT, but panoramic radiograph will serve as a scout image. So it acts as an image to before and probably after implants are placed to monitor the patient on a regular basis, the condition of the implant, especially if there are multiple implants in different locations. This is another patient with an example of a maxillary implant. Important what it is to notice is that the implant should not be close to the floor of the sinus and should be away from the sinus floor. It makes you understand that it's important to note that you are within safe normal bone. Okay, this is a case of hypodontia. I want you to pay attention to note that there are a few teeth missing here. You would have identified them by now. So like I told you, follow the pattern of examination right from the first number 1, 2, 3, go to 4 and you see that the third molar is probably not there. So 7, 6, 5, 4, 3, 2, 1, 1, 1, 1, 2, 1. Oh, there's something missing here. No, 1, 3, 1, 4, 1, 5, 1, 6, 1, 7. When you come to the mandible, you will notice that this is a developing tooth bud of probably a third molar or maybe a second molar, and then you will notice that there are some spacing here, right? So this patient is having the first molars which are or maybe the second molars which are missing, and this is the third molar already. Okay. So moving on, this is a single edentulous impacted tooth in a patient. Now you must be wondering, why did they even expose this patient to panoramic radiograph? It's important to notice that this is actually within a well-defined bony saucerized area. So this particular case, I remember, was actually covered with soft tissue, and when they made the dentures, they didn't realize that there was an impacted tooth left behind until the radiograph was done. So the patient kept on constantly complaining of pain on wearing the dentures, and when you actually took the radiograph, this is what they discovered. All right, so let's move on to look at some cases of periodontitis. Now, when you're looking at a panoramic radiograph with extensive amount of bone loss, is generally recommended when there is more than 6 mm bone loss. So in this case, you can see that there's generalized loss of bone. Bone appears resorbed, and some of the teeth appear to be actually floating in the soft tissue. Right, so this way, a panoramic radiograph serves as an important tool to get an idea of overall bone loss that has happened and whether the patient is indicated for total extractions or should the patient go for individual periodontal therapy. This is another case of extensive amount of destruction of the bone. What is important to note here is that the horizontal bone loss is a panoramic radiograph is advisable when you're expecting generalized horizontal bone loss greater than 6 mm, which is definitely evident over here, and vertical bone loss, you're seeing bony defects as well as furcation involvement. All of these can be appreciated on the radiograph. Nextly, let's look at mixed dentition. So we've covered some overall evaluation of dentition, and we've covered periodontitis. Now I'm moving on to cases of mixed dentition. A panoramic radiograph can be very useful when you're looking at mixed dentition because you want to visualize the condition of the succedaneous tooth, the tooth that is going to erupt. When you're looking at panoramic radiographs of children, it is very important to count the teeth. Please be aware of the midline and count the teeth in the first quadrant and the second quadrant, third and fourth quadrant, so that you do not miss out on any impacted or missing teeth. Right, so it's important to understand that this is deciduous, 5, 3, 5, 4, and 5, 5, and these are the canine and premolars which have not yet erupted. This is the second molar, right? If you can see the shadow of the tooth bud of the third molar, which is already here, but obviously there's a long way to go. So looking at this mixed dentition, it is easy to guess the age of the child. So that's why the panoramic radiograph acts as a very important tool in forensic evidence as well. Especially children who are below 18, and this is a very vital tool which helps you determine the age of the child. So just looking at this, you're already able to say what the age of the child would be, a range which is within 6 months. All right, so canine is not yet erupted, so I would want you to guess in the chat box what the age of the child would be. So I would like to move on while you are all looking at it, right, to the next picture. Here, I want you to pay specific attention. Again, it's mixed dentition, a lot of teeth here, lots going on. It can be quite confusing, but we just focus and scan the panoramic radiograph the way we do from number 1 to number 9. And if you notice, there are some interesting things happening here. I want you all to jot down what you're looking at, and we'll discuss it later on, right? But I can give your attention to particular area in the first quadrant. In the second quadrant, like I told you, count the teeth. So when you are counting the teeth, you will notice some very interesting facts. That is this. These are supernumerary, unerupted, permanent teeth. Right? Now, how do we know it's supernumerary? Because we just count the number of succedaneous teeth. And this is the canine, first premolar, second premolar. So what is this? That's just a supernumerary teeth. Again, on the second quadrant, canine, first premolar is already erupted, second premolar is on its way. And what is this? This is a supernumerary teeth, right? So that's how a panoramic radiograph can be a very valuable tool in mixed dentition, especially if there is delayed eruption or early eruption, or if there is indication of orthodontic treatment, then this could act as an important tool. Okay, so keeping this in mind, let's just move on and look at some impacted teeth. Like we discussed in the indications, panoramic radiograph is a really important tool to locate the position of impacted teeth. Are you with me? I hope all of you are concentrating and I'm not dozing off. This is my cat and she loves to sit on the sofa. So I hope I have woken all of you. So moving on, we are actually looking at impacted teeth. Right. So impacted canines bilaterally and having a normal dental follicle. When we're looking at impacted teeth, the most important area to look at is the crown of the tooth and the follicle around the crown. Now, in radiology, there is a rule that if this space is greater than, let me just write it down for you. Greater than 5 mm. Okay, the dental follicle, if greater than 5 mm, then definitely you are looking at a problem area. And what problem area is that? It is a dentigerous cyst. But this case is considered as a normal dental follicle. Remember, the dental follicle attaches to the neck of the tooth. Right? So that's the reduced enamel epithelium, which the crown will break open and will erupt in position. So in this case, you will see that the deciduous canines are still retained and both the maxillary canines, both 1-3 and 2-3 are still impacted. Okay, so that is what we were discussing. Okay, so this is normal dental follicle, anywhere between 1 mm to 2 mm to even 3 mm, right? Anything more than that is called hyperplastic follicle, and anything greater than 5 mm is definitely a dentigerous cyst. And now, which is the area that you measure? It is from the crown to the end of the follicle. Right, so with that regard, I want you to look at this. Now, this is one of the papers that we had published a couple of years ago. These are kissing molars. And it's a very interesting finding. Very few cases reported in the in literature. Okay, this is a case that we'd seen in 2014 where a patient reported for orthodontic treatment, and then we noticed this. So both the third molar and the second molar mandibular on both sides seem to be kissing each other. They're facing each other in the crowns facing towards each other. This is a very interesting case. But the sad part is very difficult to upright the second molar and in this case. So eventually the patient actually had to, the treatment planning was such that both the molars should have been extracted. That means he would have lost 4 molars, both the impacted third molars and the second molars, but the patient did not agree for treatment and he chose to keep them the way it is. So this is a case of kissing molars. Right, so I will move on to radiolucencies now, one of the most important indication of panoramic radiograph, to look at various types of radiolucencies. I'll give you more examples so that you can understand. Okay, so we're still retaining the impacted canine, very important area to look at. Here you can see that the 2-3 is impacted, right? So, but what I want you to pay close attention to is like I told you, the neck of the tooth. any follicle or any widening around the neck of the tooth more than 5 mm is considered as a cystic area, most commonly a dentigerous cyst. So if you pay attention to this large radiolucency here in this panoramic radiograph, you will know that this was a cyst. All right, so within the 3 centimeter size, and it was under the nose area, and you could barely see it clinically. Right. So this is a case of an of course, differential diagnosis can be an odontogenic keratocyst because of the anterior region being involved. It could be an adenomatoid odontogenic tumor and calcifying odontogenic cyst. So for those who are not yet familiar with oral pathology background, I would want you all to read up about these terms. Cysts and tumors which have predilection to the maxillary canine area. These are one of the most common in the order of that I've written down in the order of differential diagnosis. Right? So I will move on further to some more radiolucencies. Now, this is another case where you're seeing a large radiolucency in the mandible. There are septae which are visible within the radiolucency. That means it is a multilocular radiolucency. Right? So that term I have not written down here, but probably you could keep in mind multilocular radiolucency. So when you're interpreting any pathology in a radiograph, it's important to keep in mind the principle of radiographic interpretation, where you look at the external surface of the pathology, the internal surface of the pathology, and the effects it has on the surrounding structures. So very clearly, you will notice that this is more than 5 cm in length and about 3.5 to 4 cm in width. The depth is something which you cannot perceive on a two-dimensional radiograph. What you can see, though, that it has actually resorbed most of these teeth, right from the lateral incisor, canine, premolars, and the molar. The first molar, 4-6, has got completely resorbed, and the resorption is in a scalloping fashion. There are locules within this radiolucency, and very importantly, the radiolucency has go on to extend into the mandibular canal. So definitely, if you were to actually see this patient will have symptoms with respect to the mandibular canal, perhaps numbness or paresthesia on that particular side. Right, so the differential diagnosis for this would be an odontogenic keratosis. Just looking at the way aggressive the cyst is looking, it could also be an ameloblastoma. Mind you, we're not calling this a unicystic. It has locules, so it's a multilocular lesion. Now, I want you to remember at this point in time that radiology on its own cannot give you diagnosis. You need to correlate to the history of the patient, and of course, this radiographic information should be followed by biopsy and histopathological evaluation. So that is when you put all three together to arrive at a final diagnosis. Okay, so now what are we looking at here? Now, if you look at this, and I just give you 5 seconds to see, so that's why, like I told you, important, too much of background noise, and you should be able to locate the pathology. Challenge yourself. I'll give you another 5 seconds. 1, 2, 3, 4, 5. I know it's too short a time, I will have to tell you, but that's where the radiolucency is. Right, so now in this case also you're seeing that it's in the odontogenic area, relatively well defined, and it's again looking like a single area, unicystic, but the tooth is not arising from the neck of the tooth. The tooth is almost erupted into the oral cavity, so definitely it must be either an OKC or an ameloblastoma. Of course, there could be a variety of differential diagnosis, but most commonest ones are listed here, right? So this is important to look at it. Had we missed it, this lesion would have really grown to size, and the patient would only develop symptoms much later. And by then you would have to resect a lot of portion of the mandible. So the idea is to catch the lesion early. So, and the best part is this patient is wearing braces. So that means when the first orthodontic treatment would have started and the patient was already screened, this lesion was either missed or it has grown rapidly within the time frame of the 1 year, probably the 1 year that the patient has worn the braces. So that is something very important here to note. So it's critical to evaluate and the panoramic radiograph screen the patient before applying braces or any treatment for the patient. Okay. Right. Again, another very interesting radiograph. Of course, I've given you the clue away that there is a well-defined radiolucency here also. This also is a patient who's wearing braces. Interesting, right? So in the lower mandibular area, sometimes may be difficult to note, but the clue in this case was that the lateral incisor, the 4-2, sorry, I think I got the tooth number wrong. It's a 4-2. It actually turned, it discolored. So it's a root canal treated tooth. So definitely the root canal has failed, and that's why the patient developed a radicular cyst during the treatment, the orthodontic treatment of the case. Right, so what was done for this case was the re-RCT was performed, the area was marsupialized, and the cyst actually, it was a radicular cyst biopsied, cleared up, enucleated, sorry, and then the cyst healed. It was a young patient, so in a couple of months' time, he was fine and about, and the tooth was also saved. Okay. Right, so like I told you, this radiograph is absolutely normal. There are no radiolucencies seen like it's written here, but it's important to note these shadows. So don't get confused with these shadows. They are not a pathology. They're just spaces, air spaces, or shadows of the structures which are superimposed over the mandible. What is important to note is that you can still see the trabecular pattern of the bone, which indicates that the underlying tissue is normal. So this is the shadows that I was asking you not to get worried about. Okay, so this is just the shadows of the soft tissue structures which are seen. Okay, so now we'll move on to some radio opacities. I hope you got yourself some drink, or you're doing some things that can, keep you awake for a little longer. I promise you, I'll try to finish as fast as I can. Okay, so now we're looking at some well-defined radio opacities. Now this is very evidently seen in the mandibular area here, this radio opacity. What could it be? It looks normal. The teeth doesn't have any caries or restoration. It is difficult to comment on lamina dura. Remember, you're looking at a panoramic radiograph. It doesn't have that much resolution as an intraoral radiograph, but nevertheless you can definitely say that there is a well-defined opacity there, the density of which is denser than normal bone. This is actually idiopathic osteosclerosis or a dense bone island. We don't treat this, we just leave it the way it is, and sometimes they disappear on their own. Okay, so more reading about this you would want to do from your radiology textbook. Now, this is a large diffuse radioopacity, something which you cannot miss. Again, in the mandibular body on the right side, you're seeing that there is a radioopacity. This is what we typically call as a ground glass appearance. The trabecular pattern have changed and they're looking very tiny and diffuse and very ground glass like. The differential diagnosis for this could be a cemento-ossifying fibroma or even fibrous dysplasia. Since the maxilla looks all right, it's probably a monostotic fibrous dysplasia. So that's, like I told you, on the radiograph you can arrive at a differential diagnosis, but to precisely understand the pathology going on, it will require a biopsy. Okay, now this is an interesting radiograph of a tourist who visited us a couple of years ago, and actually if you look at the radiograph you don't see anything problematic because these are impacted, but definitely they're already communicating to the oral cavities, so we didn't want to bother those. But what interesting finding we noted was, other than the impacted teeth, were these radio opacities. Now these tiny opacities which are actually superimposing over the jaw don't actually belong to the jaw. They're not in the body of the jaw, but they're actually in the carotid artery which passes around in your neck. So that's where it casts a shadow. shadow. So sometimes even the parotid gland, when it is calcified, can cast a shadow. The carotid artery can cast a shadow as calcifications which can be seen. These are ectopic calcifications. They're present inside the soft tissue and not actually in the body of the mandible. So I would want you all to go back and do a little bit of reading on ectopic calcifications. They can either be in the parotid if they're in this area, or they can be in the carotid artery, or sometimes even the submandibular salivary gland. Okay. So we're nearly coming to the end of the topic. Now let's look at fractures. Now keep in mind when you're looking at fractures that a panoramic radiograph can only show you fractures which are very evident in the mandible and to a certain extent in the maxilla. If your patient has had a major road traffic accident, then probably panoramic is not the first choice. If there is head injury, or if there is major areas in the maxillary areas which have got injured, definitely a CT scan would be the first choice. Again, it depends on the condition of the patient. But for other cases which are common motorbike accidents, the one of the most commonest is where the patient falls forward and hurts the chin, because of which there are fractures. That's why it's very important to tell your patients to wear a full helmet which covers even the jaw. Okay. Now, these are some areas of fractures which you can see already pointed out by the arrow. Okay, so fracture line is something which is in-depth reading would be done, you would have done in oral surgery. So this is a parasymphysis fracture and angle of the mandible fracture. Now, when it comes to fracture, if there's a tooth involved, it becomes an unfavorable fracture, and obviously the prognosis of the tooth and the fracture management itself gets complicated. Okay, so it's very difficult to predict like how the fracture line would be depending on how the patient has fallen off or how the impact was. When generally the patient falls off on the chin, then you would also find subcondylar fractures, which is what is seen in this case, where you see that there is a step deformity here, the mandible is fractured, as well as you see a subcondylar fracture and an angle fracture. And again, a tooth is involved, so this is also an unfavorable fracture. After the fracture has been managed, this is how it looks like. So this patient would have had the fracture of the maxillary area as well as both sides of the mandible, which have actually been plated. You can see this metal plate and screws. So after the intermaxillary fixation is done, so this patient has had screws, and this is after healing. How many months after healing is very difficult to tell, but definitely you can see that metal actually remains in the patient's oral cavity. Okay, so now in this case, you will notice the difference is that all the teeth are intact. So this is not a case of fracture, and you will see that the metal plates are all very symmetrical on both sides. This is a case of an orthognathic surgery. In fact, is one of our dental students who has actually had an orthognathic surgery of both maxilla and mandible done, and it's superior results, and you will see that the patient actually looks very beautiful after the surgery. Okay. So now we're coming to the last part of the discussion. I'm talking about some faults now in radiographs. In the panoramic radiograph, most of the time these are due to positioning errors. That means you have not positioned the patient properly. That's why your image is not of ideal quality. Even though it lets you diagnose it, may not have to do a repeat in the ones that I'm showing you. Right, so this is a case where you're seeing that the gonial angles are very prominent. The patient has been placed too forward in the focal trough and the neck is bent. So that's why you're seeing that the jaw is tipping, the arch is it's like a smiling face, and the arch is tipping inwards. This is the opposite of what has happened. Like I told you, the patient, the ring experiment, which was done when we discussed it earlier, this patient is positioned to posterior in the focal trough. That's why the teeth are all widened out and it looks like a flattened panoramic image. So the teeth are too fat. This is an image again where you have lost some area in the mandible in the anterior. So probably the patient has a lot of crowding in the anterior, so he wasn't placed well enough in the focal trough. That's why the area is blurred. Also the neck is not positioned properly. That's why you can see the shadow of the spine. This is a lead apron artifact, often happens with patients who have a short neck or are not positioned properly. The lead apron actually, which is made up of metal, casts a shadow on the jaw because of the movement of the X-ray machine. Right, and so it is actually obscure part of the mandible. So this kind of a radiograph is difficult to accept and interpret. You might want to repeat it. In this case, what has happened is the patient has moved. This movement happens. That's why you see that there is a big line diagonally. Also, the neck is moved to forward and high up. The condyles have got cut. The patient's chin is not resting on the chin plate, and patient is not bitten properly on the bite block. So that's why this image definitely needs to be repeated. You have a whole area in the mandibular anterior which cannot be diagnosed properly. Now, interesting for those who are paying attention, you would have noticed something here. Now, that is, I know it's difficult to notice it. You wouldn't have paid attention to that. That's a maxillary sinus polyp, also called as could be a mucocele. A lot of us have it. It could be an incidental finding, and unless you're having stuffy nose, it can be ignored. Right, so I hope all of you have not cuddled up and taken a nap. I'm nearly at the end of the presentation. Just want your attention for a few more minutes. Okay, so we've discussed and seen a lot of panoramic radiographs. So let's just look at the strengths and limitations. The strength would definitely be a broad area of coverage. You can see all the teeth and the jaws very clearly. Relatively low patient radiation dose, ease and convenience is very easily available, accepted by the patient, convenient to take, and just 20 seconds and you have the image ready. In cases of trismus, patient is not able to open the mouth because of a third molar impaction or a fracture. Panoramic radiograph is ideal because the patient just needs to bite or stand and position themselves in the area, and you can take the panoramic radiograph. Is a very impressive radiograph when you're trying to do patient education. Your patient tries to understand and can actually correlate to what is happening in his or her jaw. With any kind of imaging come limitations. Panoramic radiograph also has its own set of limitations. It has low resolution, so you cannot compare it to an intraoral radiograph. So that means you cannot use a panoramic radiograph for RCTs and caries diagnosis. Absolutely no. You cannot use a panoramic radiograph for determining working length because there's magnification. You cannot correlate the canals and use it as a diagnostic aid for caries, right? Of course, there is magnification, so measurements cannot be reliable. Of course, the software allows you to give the right measurements based on by calculating the magnification itself. So that's one advantage. There is superimposition of real images, double images, and ghost images. So it's up to you to read the anatomy properly and catch what you want to see. And of course, it requires accurate patient positioning. If you make mistakes, you might end up with faults like that. So it's important to have train yourself and then train your technician to take good radiographs. Okay, so that brings me to the end of the presentation. I have just a few radiographs for you to check, and we can chat about it. Probably I should let you see the images first. Right, number one, I call it as catch me if you can. There you're seeing that this is a panoramic radiograph. I don't want to tell you. I want you to write down in the chat box what you're trying to see. So I give you a few seconds to see this image. So when you're looking at it, look at it from the top right corner to the bottom left corner. Remember the grid that I had told you, 1 to 9. And tell me what you're seeing. Okay, so this is number one. Okay, then I will show you number two. Again, interesting. Let me give you a clue. I want you to pay attention to the number of teeth present. So you will notice that there are some interesting findings here. Okay. And lastly, number three. Now, this can be a little complicated because there are lots of things happening here. So for the ease of understanding, probably you can take a screenshot and save it so that you can work on it in your leisure time. So let me show you all of three again. This is number 3. You could take a screenshot. Number 2 and number 1. Okay, so the take-home message is, if you're not sleeping like my cat, who can sit and sleep also, is to pay attention to details. And there you have it. These are my references, and thank you so much. I would love to thank the PVC team, especially Amalia, Kamalin, Besri, and Lukman for their effort and time. I hope they have also been able to concentrate in the webinar or not looking only at the technical aspects. Right, you can email me. You have my email ID there. And that's it from me. Yes, okay. Right, so does anybody want to ask questions? I can see a lot of questions here. Wow, most of them are thank you. Where are the actual questions? Okay. Oh yeah, the white box. Sorry, I couldn't see that. Any question? Okay. So I didn't see the answers to the anybody's typing answers for the radiograph scene? Number 2, supernumerary anteriors, very good. Anterior loop of the mandible. I didn't get that. Third radiograph about. Okay, the third radiograph was actually a complex odontome in the anterior region. Okay, so maybe you should pay attention to that again if you have taken a picture. Right. Yes, it's a periapical lesion in 3.8. You're right, me. Yeah, it is a periapical pathology. So the number 1 was 3.8 periapical pathology. Number 2 was impacted supernumerary teeth. And number 3 was anterior complex odontome. Okay, well, that's it from me. So if you have liked this webinar, please tell the PVC team. And if you want to hear more such webinars, please tell them what the topic that you would want to listen to, right? Supernumerary considered as mesio. I guess, yes, that was having a super complex odontome, so it was looking like a complicated picture. Right. Okay. So please feel free to tell your PVC friends about what topics you would want to listen to. So I guess that's it from me and from all of us here. Please take the short quiz which is posted here so that you can claim your certificates. Okay, thank you for listening to me.